All right, so we're moving on to our next session, which will be novel interventional and pharmaceutical approaches, which I think we're on the verge of a whole new realm in the management of patients with pulmonary vascular disease and right heart failure, and I think we're going to hear some really cool things. And it will really span the spectrum between device and therapy, medical therapy, as well as theoretical approaches. So,
all right. For our first speaker, I would like to introduce Dr. Jane Leopold, who is an associate professor of medicine at Harvard Medical School, an interventional cardiologist at Brigham and Women's Hospital, an investigator and a role model for many of us trying to do both clinical medicine and science. And she'll be speaking to us about intrapulmonary artery balloon pumps.
So thank you for that very kind.
Before you start, please fill out your questionnaire. Okay.
Before Jane speaks.
Right. So, I knew this moderator panel was going to be daunting. I just figured you'd heckle me after I was done talking. Right, so today I am going to talk to you about an intrapulmonary artery balloon pump. And these are my disclosures. So the learning objectives today, well, first I'm going to talk a little bit about compliance. And I will say we heard a lot about this yesterday from the world experts who know about this and have studied this for years. So it's pretty hard to add much to some of these expert explanations we've had. But I will say that compliance is a treatment target. And we've heard this once yesterday, and I'm hoping to make the case for this today so that you'll understand why this intrapulmonary artery balloon pump is an effective therapeutic. And then I will talk to you about this intrapulmonary artery balloon pump and our experience with it. So when we think about the epidemiology of RV dysfunction, there are studies that have been done, one most recently in Circulation in 2019, looking at a large number of consecutive patients with RV dysfunction diagnosed by echocardiogram. And the prevalence of greater than mild RV dysfunction among all comers was 21%. So this is not something that is just exclusive to patients with PH. This actually occurs quite frequently. When looking at the patients who had really moderate to severe RV dysfunction, and that was about 4% of all comers, you look at them, the mean age was about 64 years, 61% were male. And if you look at the etiology of why these individuals had RV dysfunction, the majority had this as related to left-sided heart disease, but a good 11% related to PAH, a larger percentage related to pulmonary thromboembolic disease, and another large percentage due to lung disease related to hypoxia. And if you look at survival based on the etiology of RV dysfunction, patients with lung disease hypoxia out to 5 years actually had the worst survival, and even worse than those patients with left heart disease. And interestingly enough, this is really close to what we have seen in our own data from PVDomics recently, where we have just looked at patients with pulmonary hypertension and followed them out now. We're in year 5 to 6 of follow-up, and we have actually seen the same thing. So why do patients have RV dysfunction? I'll go through this quickly because we have talked about this extensively. But patients can have RV dysfunction for numerous reasons. You can either have issues with preload volume, leading to this leftward septal shift that we talked about a lot, reduced inotropy, reduced lusitropy, and excessive afterload, which is what we tend to think about and focus on quite a bit. And this excessive afterload can occur due to mechanical obstruction from PE, pulmonic stenosis from congenital heart disease, and also pulmonary vascular remodeling with precapillary PH, hypoxic pulmonary vasoconstriction. So we have to remember to think about that component as well as post-capillary pulmonary hypertension and the remodeling that goes on in the pulmonary venous and the pulmonary arterial vasculature with that disease. So what's compliance? Again, we've heard about this yesterday, but there's a relationship between the pulmonary vascular resistance and pulmonary arterial compliance. So when we think of compliance, as Anton said yesterday, think about the ease of distension of the pulmonary arteries, or really the change in volume for a change in given pressure. And we know from the typical curves that we're used to seeing that there's an inverse relationship, but a constant value of the RC time, which is the product of the PVR and the pulmonary arterial compliance. And this is important because it has implications for RV function and RV work. And again, this is the same curve that we were looking at yesterday. And what it basically tells you is that if you're a patient who's in, say, Zone A, you have a greater dynamic range in compliance for a small PVR. Zone B, you have a greater dynamic range in resistance. And interestingly, if you think about where the wedge falls into this, what the wedge does is it shifts this curve to the left. So for patients that have a low wedge precapillary pulmonary hypertension, you would be the green RC curve. If the wedge goes up, then the whole curve shifts a bit to the left. So you can see that if, as the wedge changes, maybe in zone A or zone B, you may be in a little bit different position. So if you look at RV afterload and pulmonary hypertension, and again, this was brought up yesterday as well, for patients who do not have pulmonary hypertension, they have very compliant pulmonary arteries. For patients with CTEPH, IPAH, as the resistance goes up, you see that the pulmonary artery compliance based on the RC curve has to drop. And depending upon the severity of where they are, this will tell you where you are on the RC curve. If you look at a study again of all comers, for those who had no pH, and again, these are the small triangles, passive pH, so volume playing a bigger role here, blue squares, or reactive pH, red circles, you can see the difference of how they fall out on this RC curve. So what it's telling you now is in these different types of pH, what you see are the patients may have better capacitance, and lower PVR, which is where we want to go. We want to go from the right side of this curve back over towards the left. So we want to focus on decreasing the PVR, increasing the capacitance. So when we talk here about pulmonary artery compliance, a lot of us think about this, or a lot of us who work in the left heart field will think about this related to the aorta. However, when we're talking about the RV, now we have to think about the pulmonary artery. So in the circuit of the RV pulmonary artery and resistance, when you look at compliance and then you look at the PA curve, what you can see is the diastolic pressure, where mean pressure is, your peak systolic pressure, and then this pulmonary arterial time constant. So this is the area where you start seeing a decrease in pressure over time. And when you look at compliance, again, I know we talked about this yesterday too, but just to reiterate some of these differences, 20% of the compliance in a normal person without pH is in the main pulmonary artery, the left and right pulmonary arteries. 80% of it is really located beyond the first level of branches. The pulsatile load here is about 25%. And when you're looking at a normal compliance, now what we're saying is typically anything over 3, but if you're in the 3.8 to 12 range in this study that was done out of Minnesota, this is considered normal and the resistance is given. For patients with pulmonary hypertension, what you see immediately is although the pulsatile load has not changed, the compliance has really dropped, and it's dropped a lot. And this actually occurs concomitant with the increase in resistance. Now, if you're thinking about, well, how does this factor in with what's going on in the systemic circulation? In the systemic circulation, 80% of the compliance is in the proximal conduit vessels. So think, elastic proximal aorta, et cetera. And the pulsatile load here is much lower. The compliance is in the 2.5 range for being normal. So we can't really extrapolate what we know from the left heart back to the pulmonary circulation. And then you can see in a patient who has systemic hypertension where the afterload is increased, you can see like this, again, doesn't change the pulsatile load, but again, drops the compliance in the aorta. So if you're, okay. Talking about pulmonary artery compliance, why is it important? Well, because pulmonary artery compliance is related to survival. And this is a study that looked at 940 patients who had pulmonary arterial hypertension and CTEPH, and this was from the PHA registry. And among those patients who had a pulmonary artery compliance greater than 3, their transplant-free survival over the course of 4 years was pretty steady and pretty high. If you look as the pulmonary arterial compliance drops, so 2 to 3, less than 1, 1 to 2, all of those patients did not do as well. We also took the tactic of using some fancy analytical methodology where we looked in a VA database and had clinical characteristics, almost 100 clinical characteristics and comorbidities for patients. And what we did is looked at the patients and clustered them according to whether they had similarities in their clinical characteristics or differences. And what we found was that there were a group of patients here who really did not go on over time to develop PH. So we called those patients who fell into those groups resilient, and they fell into what we call resilience modules. And each of these modules is actually defined by a different color here. And you can see how they all kind of sit on top of each other with a few exceptions on the outside. So the patients shared some characteristics, but others differentiated them. But it was in the patients who were resilient, it was actually their PA compliance that actually differentiated them and made them resilient. The patients who were actually at high risk actually had some prior revascularization procedures, transplants, were on dialysis, and had other high-risk comorbidities. On the right, what you can see, and this was shown yesterday too, the all-cause mortality and the hazard ratio, if you look at the curve, this inflection point actually occurs at around a pulmonary arterial compliance of 3. So higher than 3, you did really well. Less than 3, your mortality hazard ratio went up. So this kind of suggests that A, PA compliance is important for clinical outcomes, and B, maybe this is a treatment target. So if you want to target your PA compliance, then what are you looking to do? So you really want to decrease your pulsatile afterload, your steady afterload. And if you're this patient who's like B, so with severe PH, you want to move them on this curve from the right to the left. Patient A would be considered someone with mild PH, lower PVR, better compliance. So if this RC time is constant, if your R decreases or your resistance decreases by the same amount in patient A and patient B, your compliance is going to get much better in patient A. You can see the delta as compared to patient B. So what you really want to do is get that patient B as far to the left on this curve as you can possibly go. So how do you do this? Well, typically, we have patients on medications, but the majority of medications actually don't improve PA compliance. So this is just from 2 older studies, and again, this may be changing over time as we see more new therapies with different treatment targets. But again, looking at PA compliance among a group of patients on the left who had catheterization several months apart, no real difference in their RC time, so no particular difference in their PA compliance here. If you look at patients on the right, and this is a study done with oral treprostinil, there were some patients now in this hemodynamic sub-study group of 34 patients where with oral treprostinil, their PA compliance actually did improve. Patients with placebo did not. Small study, small number of patients. We need to wait for more data before we can make definitive conclusions about this. But it is promising, and it tells us that at least when we are moving forward in other clinical trials of new agents, that we really have to think about including PA compliance as a metric that we should be looking at and measuring. So what's a mechanical way to address this? Well, the mechanical way to address this is an intrapulmonary artery balloon pump. And so this is actually a sort of novel device. This is really the first iteration of this pump that was used acutely in trials, and I'll show you the data from this. But it is a long catheter with a 15 ml compliant balloon reservoir that's filled with gas, and then it has a pressure sensor on it. So looking at this, what happens? So gas cycles to and from the reservoir to the balloon in response to cyclic PA pressure changes. So in systole, the intrinsic pulmonary artery pressure is greater than the pressure in the reservoir, and this forces gas to flow from the balloon back into the reservoir. And this mimics the capacitance effect of a normally distensible pulmonary artery. In diastole, the intrinsic PA pressure falls below the pressure in the reservoir, so this reverses and gas flow now moves back into the balloon during diastole. Here, balloon inflation increases the PA pressure, restores diastolic pulmonary blood flow into the lung capillary bed. So this concept, this idea, and this pump were tested acutely by Irene Legg in Vienna. And so here, what they did is they looked at RV and PA pressures that were measured using embedded pressure wires. They measured these pressures under 4 different conditions. They had the patient at rest with the device off, patient at rest turned on the device. Then they had the patient exercise with the device off and then exercise with the device on. This was a pilot study, patient's mean age of 52, 4 women out of 10 total patients, 8 of the patients WHO class 3, 6 of the patients having idiopathic PAH, 2 drug or toxin related, and 2 with congenital heart disease. At baseline, the mean PA pressure was 48.8 millimeters of mercury, cardiac output was 7, and the PVR was 6 Wood units. The total procedure time to do all of this was about an hour, no complications from testing this up to 30 days. So we had this at rest. So what did they see? So at rest, when the device was on, the pulse pressure decreased from 47.6 to 44.1, but statistically significant. Cardiac output increased from 6.8 liters per minute to 7.5, again statistically significant. And RVPA coupling improved from 1.01 to 1.27, again also statistically significant. And what happened with exercise? Well, with exercise, again, with the device on, cardiac output improved from 8.5 liters per minute to 10.3 liters per minute, and RVPA coupling again improved from 1 to 1.26, both statistically significant. This again just shows now what happened to compliance, again, because this is what we're trying to improve with this. With the device on, there was at rest a 20% increase in compliance with the balloon on. Exercise, a 40% increase in compliance. Again, both statistically significant. So this was a really interesting and very positive pilot proof of concept study, which led to the idea that, well, if you can implant this, it works at rest, it works at exercise, and if you could actually have this implanted, that this would be beneficial for patients under usual everyday conditions. And so what this led to was a design of an intrapulmonary artery balloon pump, and it's shown here on the left. And so what this is there is an anchor that's on the left. How does this come out? Okay, so this is an anchor that anchors into the pulmonary artery. For anyone that has seen a TAVR valve, this is exactly the kind of anchor for one of the TAVR valves that you see that goes intravascular and stays beautifully in position when you deploy. This is the balloon here, and then this is actually tethered to a reservoir that is also implanted, filled with gas, and has a port so that you can actually add more gas as needed to the reservoir. This device is being investigated in the Aspire PH trial that is being sponsored by ARIA. This is treating pulmonary arterial hypertension using the device, and it's actually, the study is expanding so that it's looking not only for patients now with group 1 PH, but also groups 2 and group 3. If looking at the initial inclusion criteria here, looking for patients with mean PA pressures 25, there are some echo criteria, PA compliance less than 3, so again, focusing on that value of PA compliance, and patients who are really symptomatic despite medical therapies. The study design, this is really a phase 1-2 single arm study. It's not randomized, it's feasibility, looking at safety, and to figure out what the effects are on pulmonary hypertension and right heart function. Again, as I mentioned, expanding to group 2, these are some of the inclusion criteria for group 2 patients, and really, what's being looked at in the study. So at Brigham and Women's, I had the honor of being able to implant this device together with Eileen Harder and Aaron Waxman. The three of us really spent some quality time together in the cath lab with this, so we're going to talk about this. But before the patient is even considered eligible, there are anatomic considerations taken into, there are anatomic considerations that need to be met. And so what has to happen is the balloon resides in the pulmonary artery past the pulmonic valve, and the anchor goes into the left pulmonary artery. So we have to have a pulmonary artery of the right width, the right length, and we have to have space in the left pulmonary artery in order to be able to deploy. So all patients get a CT scan, they get a 3D reconstruction, and then the device is mapped onto the 3D reconstruction to make sure that we have enough space to put this. So, okay. So in our patient, the case is done, in the cath lab with TEE guidance. The patient actually started and had a right heart catheterization to measure pre-procedure pressures. The patient then also has a DSA subtraction for the left pulmonary artery to ensure that we don't have any clots, there's nothing that we're missing. And then we use a large guiding catheter that you can put into the left PA over a wire. This is for the left heart people, this is exactly like putting a guide catheter up to the coronaries, only now we're doing this over a wire into the left pulmonary artery. Okay, so then, once this guiding catheter is in place, what we do is we are delivering here this sheath, through the sheath. Actually, what we're delivering here is the segment that's going to reside in the pulmonary artery. And you can just see this coming through the guide, through the right heart, towards the left pulmonary artery. And when we deploy it, we actually unsheath this. And what this shows here is we're pulling back the guide. But what you can see now here is this is well deployed, just sitting in the left PA. And you can see here there's a line or a wire that's actually going to be brought back and make a connection to the reservoir, which actually gets done after this is deployed. So anchor is here. Anchor will continue to expand until it's fully deployed. And this is typical for what happens actually with some of our TAVR valves or other valves. So now when we're deployed, and again, you can see the TE probe, what you can see here is there's an initial fill of the reservoir, and you can see the gas moving through the balloon. So this will continue to fill over, we fill it several times over a couple of days, and there's an equilibration that takes place between the gas and the patient, and then slowly bring this up until it's fully filled. The wire here too then goes to a tunneled line that goes to the reservoir, which is implanted actually in the abdomen. And through that, very easy to just actually insert a needle and fill with gas. And so here, this actually shows you the final position now with actually more gas filled in here, and it's opening and closing. Now, what's kind of really interesting about this too, and I'm going to see if I can play this for you, is that one of the CCU attendings had a stethoscope with a recorder on it. And when you listen to what the balloon sounds like inflating or deflating, I'm going to see if I can get this. So what you hear is, I mean, it doesn't sound like a normal S1, S2. You know, what you can hear actually is the balloon inflating, deflating in the middle, and it sounds distinctly different. And so when they listened to this the first time, they were completely mystified until we realized that they were hearing the balloon inflating, deflating. So what happened with our patient, and this is really amazing. So when looking, we made measurements with the device off, we made measurements with the device on. Her stroke volume, or patient's stroke volume here, went up 24% with the device on. Cardiac output went up 24% with the device on. PA compliance up 43% at rest. In the acute trial, that it went up 43% with exercise, 20% at rest. In this particular case, we got this at rest. And her systolic PA pressure didn't drop that much, and the PA pulse pressure dropped about 13%. But again, these were really impressive acute hemodynamic changes that we were able to see with the device. So for the key points, I want to just say that RV afterload, and again, you know, based on a 3-element Windkessel model, which I didn't really get into, but we have to think about resistance, impedance, and compliance. Don't forget compliance. That 20% of our PA compliance is located in the proximal vessels, so this actually is a good treatment target. PA compliance, we know now from several studies, several different groups, is associated with survival. So again, another great reason that this should be considered a treatment target. And the intrapulmonary artery balloon pump actually improved PA compliance in a pilot study and acutely in our patient with implanted device. So just a small plug, if you haven't heard of this too, The Aspire PH study is ongoing, open to enrollment. This phase 1/2 trial, look for the study, look for the results of this for when it comes out. It will provide a lot more information from more patients about this intrapulmonary artery balloon pump. I just want to thank and acknowledge the BWH team who were instrumental actually in getting this whole study, first patient through, other people, Paul from MGH, other folks who work with us, and Spencer, who was with us every step of the way. So thank you.
Yeah, sure. Good job. Okay, whoops. So it's my pleasure to introduce our next speaker, who is Marius Hoeper from Hanover, Germany, Hanover Medical School, who yesterday volunteered to take every one of my transplant patients if I can get them there. He's the I'm not going to introduce him anyway. Everybody knows who Marius is.
but Marius doesn't know how to use the system here. So, where are my slides?
Oh, you need to close.
Oh, yeah, close that.
Okay. All right. So, Aaron, this is just an amazing symposium here. It's unbelievable. And also, the questions are always a bit tricky. My task is targeting BMPR2. And I thought you wanted me to talk about sotatercept. And the first point is we don't target BMPR2 with sotatercept. That's one point. Where are we? That's pretty easy. Where do we go from here? I don't know. So this is basically where we are. So, and yesterday we discussed a bit of sotatercept already, and I had a feeling that many things I'm going to say may trigger some debate. So I think I should start with something that is less uncertain, maybe not my disclosures, but I think we all agree that this is the problem we're dealing with, right? This is the fundamental, the key problem that we're dealing with when we treat patients with pulmonary hypertension. And we like to prevent this, but the problem is that still our patients come when they have a very advanced stage of the disease. At least fortunately, over the past 20 years or so after discovery of the BMPR2 mutations, we have at least learned that first of all, the animation here is not really moving, but behind it you see a sketch that you have seen several times before, that there is a tightly balanced system among members of the TGF-beta family, including activins, including other factors that regulate the homeostasis of pulmonary vessels. And the disbalance here is one of the drivers of pulmonary vascular remodeling. And there are some daydreamers out now who believe that it may even be possible to achieve something that we'd like to call reverse remodeling by when withdrawing the growth factors that these cells need to stay alive and stay in the lumen in order to occlude it, just disappear because they go into apoptosis or some other kind of cell death. And we never really knew whether this would be possible in humans. Thanks to the beautiful studies by Paul Yu in the paper in Science Translational Medicine, at least we saw that it's possible in preclinical models and animal models of pulmonary hypertension, but we never knew really how relevant this is in human disease until we had this first compound here of this new class of drugs, which is officially called activin signaling inhibitors. Sotatercept here, which is an activin ligand trap. So it's basically the active part of sotatercept is the extracellular domain of the type 2A activin receptor. It's a ligand trap, so it binds activins, AB, and others, growth differentiation factors, and also some BMPs here. And the idea is to restore the balance and then see what's going to happen to the pulmonary vessels first, but then also secondary to the right ventricle. And the clinical data that we have can be summarized quickly. So we have, first of all, the phase 2 study out published in 2021, and here sotatercept was administered in 2 dosages, 0.3 and 0.7 mg per kg administered every 3 weeks. Primary endpoint was changed in PVR from baseline at week 24, and the study was positive. There was improvement in PVR with both dosages, and there was also improvement in 6-minute walk distance. You see there's some disconnect here. With the 0.3 dose, there seemed to be a little bit less improvement in PVR, but more improvement in 6-minute walk distance and vice versa. And of course, there was some discussion about the target dose then for the currently ongoing studies. And fortunately, the decision was made to base really the thoughts or the decisions on the hemodynamics and not on 6-minute walk distance, even if 6-minute walk distance was clear to be the primary endpoint of the phase 3 study. And then we had the open label extension of the study. So followed patients for 18 to 24 months, and which showed basically that patients who were initially randomized to receive sotatercept showed the continued improvement in PVR, 6-minute walk distance, NT-proBNP over time. There was no further improvement, but it was more or less stable. And those patients who were originally assigned to placebo, they kept out. They had the same improvement than the patients originally assigned to the active drug. And what we also learned from this study is what is the side effect profile of sotatercept, which is quite unique and wasn't really seen in the main study. And when you just focus on the very left and the very right column, you see that the typical side effects are bleedings, mostly epistaxis. There's an increase in hemoglobin, which is linked to the mode of action of the drug. Some usually mild thrombocytopenia, and the development of telangiectasia, all of this in the range of 10 to 20% of the patients over this observation period of 2 years. So this is basically what we had when we entered the phase 3 study. And you know, the phase 3 study program has 3 studies, and one is completed and published, and this is Stella. And Stella was published and released at ACC earlier this year. Jane and others were there, and it was quite an event for many of us, because I think it really opened the door to a new treatment era in our field. So Stella design was very similar to the PROSA design, which I didn't show in detail. So we enrolled patients with a diagnosis of pulmonary arterial hypertension, like in other studies, pre-treated. They had to be stable, functional class 2 or 3 with a certain 6-minute walk distance. The patients were randomized 1-to-1 to receive either sotatercept, now the target dose of 0.7, or placebo. And the primary readout was a change in 6-minute walk distance at week 24, of course, based on the recommendations from the FDA. And there were several secondary endpoints tested hierarchically, all of them also at month 6, except for time to clinical worsening, which was assessed once the last patient had completed the week 24 visit. So all patients were kept blinded and up to that time, which was quite relevant. And we also had right heart catheterization and an echo at baseline and week 24, and we'll come to that. The study enrolled the patients that it was supposed to enroll, so patients with typical form of pulmonary arterial hypertension, mostly idiopathic heritable, but also some other forms of PAH, relatively young, predominantly female patients, functional class 2 or 3, very prevalent patient population. In PULSAR, the average time from diagnosis to inclusion was 8 years. Here it was even 9 years. Still, the patients had severely impaired hemodynamics. They were heavily pretreated, most if not all of them on combination therapy, dual or triple, 60% on triple, 40 of them including parenteral prostacyclins. So the study met its primary endpoint, so 6-minute walk distance improved by approximately 40 meters at week 24. There was also a very consistent improvement in 8 out of the 9 secondary endpoints, including multi-component improvement, which is a composite of improvement, 6-minute walk distance, functional class, NT-proBNP, PVR improved, NT-proBNP, the French low-risk score, time to clinical worsening, and importantly also 2 out of 3 domains of the PH-SYMPACT, which is a disease-specific quality of life tool. And then there was time to clinical worsening. This really dramatic risk reduction, 84% risk reduction in clinical worsening events, which is a composite endpoint. And everything here favored sotatercept, be it hospitalization or deterioration, even mortality. Even the study wasn't powered for mortality. And even if the numbers are too slow to claim a signal here. Safety, tolerability on the other side, also I would say quite favorable. Of course, there were more treatment emergent events related to, or here in the sotatercept group. However, all these events leading to treatment or study discontinuations, leading to death, or were considered severe or serious, were all more common with placebo than with sotatercept. So this is basically where we are, and the side effect profile is very similar to what I showed you from the PULSAR open label extension study. So we saw basically the same side effects here. Now certainly more robust numbers. So again, the bleeding events, mostly epistaxis, some gum bleeds, usually mild, usually not needing intervention, but it's there. Telangiectasia develops now in up to 20% of the patients. This is also what we see now in the ongoing studies in which patients are maintained on sotatercept. We have the increase in hemoglobin. The average or the median increase is 1.3 gram per deciliter. We have thrombocytopenia, mostly mild. The average drop is 15,000. But some patients develop relevant thrombocytopenia, although it's very rare that patients have to discontinue treatment because of that. And then there's an increase in blood pressure. Also, this is a finding that was fairly new in this study, but something that has to be kept in mind. Most of the patients, almost all of these patients, continue the study despite these side effects. But we're early. This is all early signals here, and we need to see what's going to happen with true long-term administration of the drug. Later this year, 2 months ago at ERS, we presented and published post hoc analysis from the STELLAR study, looking really in depth on the hemodynamic findings and on the echo findings. And I think this is the right place, this is the right symposium to present these data here and discuss these data. And I must say, I very much like the STELLAR data, but these data I find truly exciting and thought-provoking. And so what we have here is, first of all, when we look at the left side or the systemic side of the circulation, I mentioned the increase in blood pressure. It's about 4 millimeters of mercury, both systolic and diastolic. You could say it's not much, and for most of the patients, it's certainly not clinically relevant, and at least for some patients who start with a low blood pressure, which is not so uncommon in patients with PAH, it may be even beneficial, but some patients you have to treat. Sometimes, of course, it's more than that. And the signal is basically what you get from many hypertensive drugs the other way around. This is not very uncommon that you have an average decline in blood pressure in these trials of 3, 4, 5 millimeters of mercury. So it is something, and we have this increase in the systemic vascular resistance with this drug. And the left heart, the end systolic and end diastolic dimension of the left ventricle do not change. But we have a drop in the left ventricular ejection fraction. We were very surprised by that. It's 2%, you can say it's only 2%, but it's statistically significant. And again, it's after a fairly short observation period. And of course, there's an ongoing discussion. Is this an intrinsic effect of this drug on the myocardium? Is there some myocardial depression here? Or is this just a change in the sympathetic nerve tone? Or is it just related to the increase in SVR that we just saw? Clinical impression so far is that it has no relevance from looking at these patients. But again, it's early data, we don't know for sure, and this is something we need to follow. Then on the right side, of course, we have this decline in the mean pulmonary artery pressure of about 14 millimeters of mercury. This is something we have never seen before with any other intervention in pretreated patients. It is really huge. On the other hand, we have basically no change in cardiac output. This is also very uncommon. It triggers a lot of discussions, something I think we all do not fully understand yet. Antoinette yesterday issued some possible explanations to that. So the drop in PVR that we saw here is entirely driven by the decline in the mean pulmonary artery pressure, no change in cardiac output. That's quite surprising. It is unique among all the drugs that we use, but all the drugs that we use to treat pulmonary hypertension are not selective pulmonary vasodilators. They all have a systemic vasodilatory effect, which is probably related and perhaps even the main cause for the increase in cardiac output here. We have interventions where we act selectively on the pulmonary vessels. For instance, pulmonary artery denervation, also balloon pulmonary angioplasty. And if you look at these data, there's also very little increase. I'm not saying improvement, I say increase in cardiac output. So it has to do, or it is related at least to some extent to the systemic effects or lacks thereof of the interventions that we use. Then a deeper look, let's say, in the hemodynamics. Jane, as I've mentioned, we have to look at pulmonary arterial compliance, which we usually don't do in clinical trials. So at least here we have the data. There's quite a substantial increase, 0.6 here. When you compare this with the data that have been shown yesterday and today with other interventions, it's quite substantial. And also the right ventricular work, so the product of the mean PA pressure and cardiac output declines substantially. So I think Anton said yesterday it's like paradise for the right ventricle. So there's a huge reduction in afterload. It's reflected by the drop in the right atrial pressure. It's about 3 millimeters of mercury, and the patients start at an average of 8. It doesn't seem a lot, but it's, again, the largest drop in the right atrial pressure that we've ever seen in any clinical trial in our field. It is substantial. And then the echo parameter. So we really compared the hemodynamics obtained from right heart catheterization with the echo, which was central read here. And first of all, there was no change whatsoever in TAPSE. TAPSE did not change with sotatercept. However, due to the drop in systolic PA pressure, of course, there's a huge change, a huge increase in the TAPSE over SPAP ratio, which is an echocardiographic marker, a very simple marker of coupling, of RV-PA coupling. I didn't really believe in that, but I think most of our community now start believing that it really works. It really has a meaning, and this improvement that we see here is quite substantial. And then it's also reflected by the declines that we see in the end diastolic and end systolic area of the right ventricle. It's about 22 to 25% or up to 30% decline that we see here. So it's also it's not just a little bit of, let's say, shrinking of the right heart chambers. It's more than that. And there's a little bit of improvement, only 2% in the fractional area change, but it is statistically significant. And then at the same time, this translates to a remarkable improvement in the degree of tricuspid regurgitation. Once again, something we haven't seen with other treatments, although I must say that many of the studies that have been done with other interventions didn't really look into that, but there's quite a substantial improvement. So we came up with this graphical abstract. It's one of the first graphical abstracts ever published in the ERS. I like it a lot, I must say. And so what we have here is basically we have an intervention which we believe acts on the pulmonary vascular bed. There may be some reversion modeling here. We can't prove this, but there's certainly some meaningful unloading of the right heart, which is demonstrated by the drop in the PA pressure, by the improvement in compliance, right ventricular work. You see here the effects of unloading by the drop in right atrial pressure and NT-proBNP here, and the coupling improves. So there is a substantial decrease here in the size and the dimension of the right heart chambers and tricuspid regurgitation. So yesterday, there was also discussion, what is right ventricular remodeling? I think we do see here some right ventricular remodeling, although we don't know the ultrastructural on the histological effects of this kind of treatment. Usually I stop here. And use this as a summary slide, but Aaron had this point in asking me what's going to happen, and no worries. This is just one more slide here. But sotatercept is the first in class of the activin signaling inhibitors, but it's not going to be the only one in the years to come, because there are other drugs now on the horizons. And at least two that I know of have now entered or start entering the clinical trial program, the phase 1, phase 2 trial program soon, or just start enrolling patients. And one is called KIRO-2, and the other is HS135. And both of them have in common that they are not type 2A, but type 2B activin receptor type molecules. They both have, like sotatercept, a high binding affinity, maybe an even higher affinity to activins and some of the growth differentiation factors. They have a different binding profiles of BMPs. And we don't know yet whether these different profiles lead to any difference in terms of efficacy, whether they are as efficacious, more or less efficacious than sotatercept. Of course, we don't know. There may be also a difference in the side effect profile. For instance, what you can see with the Keros compound here, this is hemoglobin. There's no change in hemoglobin. And the same is probably true here for the other compound. And also some of the other side effects may be different simply because of the different binding profile here. I think we will learn this by seeing the data from the study. We can speculate what's going to happen, but no one knows because the system is so complex that I think there's not yet full understanding of this. But by just using different approaches here to the system, I think we will get a better and better understanding and eventually find out what the optimal drug is to target this pathway. And with that, I spare you a summary, and I thank you very much for your attention.
Okay. Moving on to our next talk, I'm going to welcome Professor Sebastien Bonnet up to the podium, and he is a professor and director of the Pulmonary Arterial Hypertension and Vascular Biology Research Group at the Heart and Lung Institute of Quebec, and he is going to talk to us about metabolism and whether it is a potential viable target in therapy.
Thank you very much for the kind introduction and the invitation to this symposium. I feel being like the black sheep of the program, being probably the only basic scientist who's going to give a presentation. But thank you. And I like to be controversial like my colleagues from the Netherlands, Anton. So I feel okay being the only basic scientist presenting this morning. The second task that I just realized, I've been asked to present something on metabolism and if there are any room for other therapies in pulmonary hypertension after a talk on sotatercepts. And everybody knows that sotatercepts have clearly changed the field of PH and development of new drugs. So I like challenges, so I'm going to try to convince you that there is maybe room for other pathways and other drug development in pulmonary hypertension, especially related to metabolism. So these are my disclosures, the learning objective. So I'm going to give you a brief overview of the basic researcher views of what is pulmonary hypertension for us, discuss what is metabolism and what are the way to target metabolism, and show if there is room for clinical improvement using anti-metabolism drugs, and also present some new stuff going on in the lab related to metabolism and epigenetic reprogramming in pulmonary hypertension. So this is the equivalent of a 3D MRI for a basic researcher. We call that a schematic. And a schematic here is designed to explain you how we see pulmonary hypertension. So this is a normal, healthy distal pulmonary arteries with a single layer of endothelial cells surrounding by smooth muscle cell and some adventitial fibroblasts. For reasons that we still don't know in the field, stress, mutation, DNA damage, inflammation, these endothelial cells are going to become sick, they're going to die. Some of them is going to start to release a lot of things, which is going to make the surrounding smooth muscle cells becoming crazy, hyperproliferative. Same for the fibroblast. And with time, this healthy distal pulmonary artery is going to become looking like this, and with more time, like this. We know from animal studies that before seeing any symptom in animals, you need to have at least 60% of the distal pulmonary arteries to be obliterated to have sign of pulmonary hypertension in animal. And from this to this, it takes a lot of time. The consequences of this on the right ventricle, I know that my colleague from Germany believes everything is from the lung and only the lungs, but there is consequences on the RV. We know that now. The response of the RV there is increase of resistance because of this remodeling. So the RV is going to start lifting weights to become stronger, to be able to push the bloods against the resistance. And as long as able to become strong and push the blood, cardiac output is maintained and everything is okay. But rapidly, there is a transition from a compensated hypertrophy to a decompensated hypertrophy and dilatation, which caused the death of the patient, unfortunately. From a metabolic standpoint, the vascular remodeling process and the remodeling of the right ventricle is associated with a lot of abnormalities at the mitochondrial level. So the mitochondria are the small organelles within the cells that generate energy, ATP, that sends oxygen but also regulates cell death. And the way it's doing that is through the regulation of its membrane potential. And in pulmonary hypertension, this is cells, smooth muscle cells, isolated from non-PH and PH patient. And the red is assessing the membrane potential of the mitochondria. So you see a lot of reds in PH, both in the pulmonary artery smooth muscle cells and in the RV, which make mitochondrial hyperpolarization. So mitochondrial hyperpolarization, basically, it's a signal for mitochondria are shut down. No energy production, no cell death, everything is shut down. The mitochondrial reactive oxygen species are the byproducts of energy production by the mitochondria. So when there is no energy production by the mitochondria, reactive oxygen species produced by the mitochondria are done. Less red in pulmonary hypertension and the RV. But how the cells are producing energy if the mitochondria are shut down? They are using glycolysis, cytosolic way to produce energy, which is glycolysis. And to do that, they activate a lot of transcription factors that are going to tell the cells, well, you need to express this protein, and this enzyme to make the production of the energy from the glycolysis. And one of these big factors is the hypoxic-inducible factor 1, HIF, that is super active in the distal pulmonary arteries and the right ventricle of patients with pulmonary hypertension. Consequences of that was illustrated yesterday by a beautiful presentation from my friend Paul Yu, which shows the PET imaging, and you see an increase in glucose uptake both in the lungs and the RVs from patients with pulmonary hypertension. So all these observations have been replicated by many labs over the past 5-10 years, and we have established what we call the metabolic and cancer theory of pulmonary hypertension, because all this mitochondrial dysfunction that I presented to you are also present in cancer. So that's why we believe there is a lot of analogy, even if pulmonary hypertension is not a cancer. So there is two big paths in the application of metabolism in pulmonary hypertension, the one that I just presented to you with mitochondrial dysfunction, and another one that I will be mentioning in the second part of my talk, which is the generation of acetyl-CoA and the reprogrammation of gene expression through epigenetic and histone acetylation. So how can we're going to first look at this first pathway and see if there is drugs that could reverse pulmonary hypertension by reprogramming the mitochondrial function. And I'm going to be presenting you one of them, which is the dichloroacetate that has been used both preclinically and clinically to remove vascular remodeling. So this is a cell, this is the bloodstream. So this is the mitochondria here. So glucose coming from the blood goes in the cell, cytosols, everything goes fine here. And at this stage, where you are at the pyruvate, if the mitochondria is well, the pyruvate goes and go in the mitochondria in the Krebs cycle to generate ATP with the electron transporter chain, etc., etc. In pulmonary hypertension, the transporter, the enzyme responsible from transporting the pyruvate within the mitochondria, which is the pyruvate dehydrogenase, is totally locked down. And this is a Western blot assessing the activity of this enzyme that can allow pyruvate to go in the mitochondria, which is significantly repressed, so phosphorylated in pulmonary hypertension compared to control. And the reason this is blocked, it's because this enzyme, the bad enzyme, are significantly upregulated. So one way to reverse this will be to have a drug that can significantly remove the lockdown of the PDH, allowing the pyruvate to go back in the mitochondria again and reprogram the mitochondria and the function of the mitochondria, which is energy production, but also cell death regulation. And this has been done with, I'm not presenting all the preclinical studies. I'm directly going to go to the big rats, which is the humans. And there has been a phase 2 clinical trial that has been published by Professor Michaelakis and Martin Wilkins from Imperial College, published in Science Translational Medicine, so very good journal. And they showed by MRI here and measuring the perfusion of the lungs. So before DCA and 4 months after DCA, the same patient, they show a significantly improvement in lung perfusion, and they also showed that there is reduction in the shape of the RV, reduction of the pressure, so the flat septum here is becoming more normal. They also showed that in many patients there is a reduction, significant reduction in mean PA pressure, so pre-DCA and post-DCA, with reduction in that situation of 20 millimeter of mercury, which was pretty interesting. And they did a PET analysis with FDG uptake and show a significant reduction in patients that received dichloroacetate for 4 months. So very interesting findings with these molecules that were able in vivo to reprogram the mitochondrial function and improve pulmonary hypertension. Now we go back to another way to reprogram the mitochondria, and this was also mentioned yesterday by Paul Yu in his talk, was playing with the Rendell cycle, and this generated the controversial question by my colleague from the Netherlands, Henton, about why we don't see decrease in PET signaling when you give a drug that blocks supposedly fatty acid oxidation. So the Rendell cycle is a beautiful thing where basically when your glucose oxidation pathways is blocked, the cells are compensating by increasing the fatty acid oxidation. The reason the cells are doing that is to produce this compound that is acetyl-CoA. And acetyl-CoA is very important because this is a molecules that generate the blocks that are necessary to make new cells. For example, from acetyl-CoA, you can generate lipids, and 90% of the membrane of the cells are lipids. So lipids are crucial for cells to proliferate and generate new membranes. Acetyl-CoA can also go in the nucleus of the cells and regulate what we call histone acetylation, which is going to open and close the chromatin, giving access to transcription factor to express or repress the expression of many genes. So this is critical to be able to generate acetyl-CoA in the cells, otherwise the cells cannot survive. So in pulmonary hypertension, where we have a lot of proliferation, we need to have a lot of acetyl-CoA. So this balance by the Rendell cycle suggests that in pulmonary hypertension, where fatty acid oxidation is supposed to be increased, if you block it, you will decrease the acetyl-CoA generated from the lipids, and the cell will respond to that by increasing glucose oxidation to try to compensate and reactivate the mitochondria. And there is a lot of papers that have been published preclinically showing very nice efficiency of blocking fatty acid oxidation in preclinical animal models, and I'm going to be showing some of them. So the first way of efficiently blocking fatty acid oxidation is to generate mice that are lacking a protein that regulates the fatty acid oxidation. So we can generate mice without a gene we call knockout mice. In that situation was malonyl-CoA decarboxylase, knockout mice in the smooth muscle cells. And when you remove this enzyme, you are blocking the ability of these mice to develop pulmonary hypertension in response to chronic hypoxia. So this is a right cat performed in a mice, in a closed chest in a mice, exactly the same way you guys are doing it in patients. And you see like the mice that lack the malonyl-CoA decarboxylase don't show any increase in mean PA pressure in response to chronic hypoxia, whereas the wild-type mice, when you expose them for 3 weeks to chronic hypoxia, the PA pressure goes from here to here. And this was associated with a significant prevention of vascular remodeling. And also, as expected, significant reduction in mitochondrial hyperpolarization. So we were able to, through that pathways, to reverse the mitochondrial abnormalities and to improve in preclinical models pulmonary hypertension. Now we cannot do knockouts in patients. We are not there yet. So we could we look for other compounds that could modulate fatty acid oxidation, and one of them is trimethazidine, which is a profound inhibitor of the 3-keto coenzyme HOLase, which also blocks significantly fatty acid oxidation. And when you treat animals that with pulmonary hypertension for 2 weeks with that compound, you were also able to significantly reduce mean PA pressure and restore perfusion of the lungs of this animal. And again, this was associated with a better cardiac output and a better 6-minute walk test performed in rats on treadmills. And this work was published as well in the Science Translational Medicine. So the second part of the talk, I hope you guys are still doing okay. You know, I know there is not a lot of Kaplan-Meier curve and all these very interesting things that you guys are doing all the time. But this is the origin of the sototarcept study. This is, you know, I think without the basic science, we have no drug. So everything is coming from this type of work. So I hope you still understand everything. I'm not going too fast. If there is anything you want to interrupt me, feel free. Second part is how metabolism can be implicated in reprogramming gene expression. Because you have to understand, in pulmonary hypertension, if the cells are proliferating, if the distal pulmonary artery are becoming totally obliterated, it's because there is things that are telling them to do so. And they have to modify their gene expression, the protein profiles and everything to make them in the condition where they can survive, proliferate, and be happy despite the sustained stress like chronic inflammation and so on and so on. So there is a lot of reprogramming. And I think this is the difference between this part, which is treating the symptom, and this part, we try to totally reverse the disease and reprogram the genes by regulating epigenetic pathways. So a new concept, I think, and very interesting one, probably my favorite one right now. And again, I always put that slide because I'm here standing in front of you, but I'm presenting the work of someone else. And the work of someone else is these two wonderful PhD students working in my labs. So I don't like to take the credit for someone else. So they are the two people behind all the works that I'm going to be presenting now. So everything is thanks to them. So histone acetylation and acetyl-CoA generation. So to make things very simple, there is two big enzymes that can generate acetyl-CoA within the cells, which is the ATP citrate that can produce acetyl-CoA from the citrate, and the ACSS2, which can produce acetyl-CoA from acetate. There is also a couple of other ones, but we're going to keep it simple here. So we're going to be looking at these two guys here. And these two enzymes can either generate acetyl-CoA in the cytosol to produce lipids, which are important for the membranes, as I mentioned earlier, but they can also go in the nucleus and generate acetyl-CoA in the nucleus to regulate gene expression by acetylation. So we wanted to know if this metabolic enzyme could be implicated in pulmonary hypertension and epigenetic reprogrammation in pulmonary hypertension. So first, we did very basic experiment that we do every day in the lab, is Western blotting and measuring the expression and the activity of the enzyme in both control condition and cells isolated from PH patient, as well as distal pulmonary arteries from control and PH patient. We didn't see any differences whatsoever in ACSS2. Okay, good thing. We don't need to study it right now. Maybe we'll come back to it later on. We look at ATP citrate lyase, and that guy was significantly increased, both in terms of expression and activity. So Activity is assessed by the phosphorylation form of ATP citrate and the expression is the total form, and both are significantly upregulated in distal pulmonary arteries from patients with pulmonary hypertension and in isolated cells from these distal pulmonary arteries, and this is the mean data here. And you also have an idea of where it's expressed in the distal pulmonary arteries. So we see a lot of expression in the smooth muscle cells and a little bit as well in the endothelial cells. So what are the role and the impact of ATP citrate lyase on proliferation and cell death? So we use two approaches to block ATP citrate lyase. One is a molecular one, where you block the gene expression by silencer RNA, and the other one is a more pharmaceutical one, where you use an inhibitor of the activity of the enzyme. In both conditions, we were able to significantly repress and reverse, not totally, but significantly decrease the cell proliferation, so basically blocking ATP citrate lyase, block the proliferation, and restore the ability of the cells to die, which is by apoptosis. So we did that by two different approaches. One is immunofluorescence, which generate beautiful pictures. For proliferation, this is the amount of red. So when we treat the cells with the silencer RNA or the compound, less red, less proliferation. And the apoptosis is the green stuff. And when we treat the cells with silencer RNA or the inhibitors, the green stuff was increasing, so suggesting more apoptosis. And so this is a very, like I said, biased. Usually when you do that, we always do this experiment totally blinded to the treatment, but with trained eyes, you can rapidly see where there is proliferation, not proliferation. So we always like to confirm this approach by a non-biased and more specific way of assessing proliferation and survival in cell, which is, again, the basic Western blotting approach, where you measure the expression of proliferation and survival markers, which are PLK1, PCNA, MCN2, and survivin. Survivin is the survival one. I think you will understand that one more easily. This one are the proliferation, this is the survival one. And all of them are decreased by the molecular inhibition of ACLY with silencer RNA or the drug. So very interesting. Now I said that ATP citrate lyase could also generate acetyl-CoA in the nucleus to regulate gene expression. So we measure, is it true? So we measure how many ATP citrate lyase in pulmonary hypertension can go in the nucleus of the cells. And so we did, again, beautiful pictures with immunofluorescence. Red is ATP citrate lyase in control cells. You see a lot of the cytosol. This black dots here is the nucleus. It's not red, at least there is not a lot of red in the control condition, but in pulmonary hypertension, you see that most of the red is in the nucleus compared to the cytosol, suggesting that that protein goes in the nucleus. Again, to confirm that, non-biased approach, we do sec fractioning and we measure how much of the ATP citrate lyase is actually in the nucleus versus the cytosol. And it was significantly upregulated in the nucleus in pH compared to control. This is here. The consequences of that is a significant, when you block ATP citrate lyase, you significantly repress the acetyl-CoA generation through ATP citrate lyase in the nucleus. So basically we confirm the hypothesis is that in pulmonary hypertension, ATP citrate lyase goes to the nucleus and generates acetyl-CoA. Okay, so we demonstrate this here. And if you block this, the consequences on histones, which are the proteins that regulates the opening of the DNA and the chromatin to regulate gene expression, the histone acetylation, which usually open the DNA to allow the expression of the gene, are reduced. So it suggests that there is less gene expression when you block ATP citrate lyase. So we believe that we are blocking the expression of the bad genes, of the bad proteins that are implicated in the proliferation and resistance of apoptosis seen in pulmonary hypertension. So I'm not going to present all this multi-omic fancy stuff that we generated to identify all the genes, because I thought this was too much for a Saturday morning. So I'm just going to go in the in vivo stuff, like more clinical oriented data sets, where we induce pulmonary hypertension in rats. We have various rat models. I'm one of them, of this basic researcher that think animal models are not the best way to study pulmonary hypertension. They are necessary because we need to do drug development, and there is no other way right now than using this animal model. As I always say in every single of my talk, we have cured pulmonary hypertension in animal model probably 500 times. And we do so maybe 100 times every year, if it's not more. So everything works in animal model. That's the beauty of it. But I think the reason everything works is because we are not using them the right way. So we can have a debate on that, but it's not the topic of the discussion today. So here it is. We induce pulmonary hypertension in Sugen-hypoxic rat model. So basically you inject a drug, this is Sugen, which is an inhibitor of the VEGF receptors. You are inducing a lot of endothelial dysfunction. Then you sustain this endothelial dysfunction by putting the animal 3 weeks in a chronic hypoxic chambers. And then at the end of that, they have a lot of vascular remodeling in the distal pulmonary arteries. They have an increased PA pressure, RV dysfunction, and so on, which mimic a lot of what is seen in PH patients, and they do have a lot of vascular remodeling. And at the end of the 3 weeks of chronic hypoxic chamber, you can let them go or treat them with the drug that we use, which is an ATP citrate-lyase inhibitor, and measure the effect on PA pressure, RVSP, cardiac output, and so on. And we're able to see a reduction. So this is what happened. You see all the dots disappear. It's the transition from a Mac to a PC. It's magic. So, the dots are gone, but the mean point is here. So there is a decrease in RVSP, mean PA pressure, and there is a slight increase in cardiac output. Vascular remodeling was also reduced here, and this was associated with a profound decrease in proliferation of the cells. Again, everybody can say, well, this is maybe drug non-specific and so on. So we decided to go further and generate a knockout mice without ATP citrate-lyase in the smooth muscle cells, and showed that these mice were actually more resistant to the development of pulmonary hypertension. So when you put these mice in chronic hypoxic chamber with Sugen injection, they develop less pulmonary hypertension than the wild-type mice, suggesting again that this enzyme is truly implicated in the development of pulmonary hypertension, and this was associated with less vascular remodeling and less proliferation within the distal pulmonary arteries. Now, to go a step further, we decided to develop new ex vivo human models where we isolated distal pulmonary arteries from PH patients that we are receiving a lot of lungs, probably 10 a year at the time of the lung transplantation in Canada, mostly in Montreal and Quebec and so on. So we are fortunate to be able to have access to this precious human tissue, and so make a dissection of the distal pulmonary arteries, and you can put them in culture for a couple of weeks, and you can test drugs on it. So we put these rings of distal pulmonary arteries in Matrigel type 3D culture systems to assess the efficacy of drugs. And here, what we showed that the inhibitor of ATP citrate-lyase in this model after 2 weeks is able to significantly repress all the proliferative pathways that are overexpressed in pulmonary hypertension. And to go a step even further, we also have generated, our friend in Germany, Sonny Pelem-City, precision cutlass slice from this PH patient. So basically, when you're receiving the lungs from a PH patient, just right after the transplantation, you are able to infuse the lungs with agarose and make very, very thin slice of these organs, like 300 micrometers, and you can keep them in culture for up to 3 weeks. And thanks to that, you can truly assess efficacy of a drug on vascular remodeling, for example. And this is what we did with ATP citrate-lyase inhibitor, and that's actually one of the ways to known if sototarcept is a true or not anti-remodeling agent would be to do the same approach in this human lungs from PH patient, expose them to sototarcept for 3 weeks and see if you have a reversal of the distal PA remodeling. And the beauty of that is you can follow the same artery over, like, take a picture every 2 days of the same artery. So you truly have a follow-up and you can compare that to the vehicle. So this is what we did here with ATP citrate lyase inhibitors and clearly show a significant reduction in vascular remodeling processes in the distal PA of human patients. So the conclusion is, I don't have a summary slide because I thought that I was explaining well enough all these pathways, and I hope I did a good job. So basically, is there any room for metabolic modulators in pulmonary hypertension? I do believe there is. Now I'm not going to lie. I think the group 1 pulmonary hypertension is crowded of new molecules coming on, imatinib, imatinib, sototarcept, and all the already standard of care, which might be a lot of drugs already available. And every time you want to do a clinical trial, you have to show efficacy on the top of all these guys. So it's becoming more and more challenges. But there is also other groups of pulmonary hypertension, and especially the group 3. And I think Dr. Leopold showed the survival of a group 3 patient based on the RV. I think this is a niche where we need to go and develop new drugs. And I think metabolic modulators have a place for this vascular remodeling diseases, pulmonary vascular remodeling diseases. So thank you very much, and I hope you enjoy and almost understand everything I said. Thank you very much.
Next up, I would like to introduce Dr. Roham Zamanian, a professor of medicine at Stanford University, the director of the pulmonary hypertension program there, and an expert clinical trialist who will be speaking with us about the age of disease-modifying pH therapies.
Good morning. Thank you very much for an interesting symposium. And thank you, Aaron and Jane, for the invitation. So after that beautiful talk by Sebastien, I'm going to talk about a topic, Aaron, that you gave me that is more conceptual. And it's going to be about the age of disease modifiers. What should our approach be to treatment? So these are my disclosures. And I think I'm going to step back and just answer the question from 2 broad perspectives. I'm going to start with our approach to treatment. And I'm going to lay the foundation for you in what do we think from a clinical perspective is the modern day approach to treatment. And then I'm going to step back and walk into what I think conceptually will be the 2 most important words that we deal with in the next decade of pulmonary vascular disease research, and that's going to be disease modification. So the state of current practice, at least from a North American perspective, and I think it's probably global as well, is that we are now at a point in time with 2 decades of extreme success in terms of stabilization of patients with pulmonary arterial hypertension. And now, except with some exceptions, maybe you might say with parenteral prostacyclins, the expectation is dual upfront therapy, generally stepping up therapy based on a risk stratification portfolio, and never really de-escalating, except for, maybe side effects or patient non-compliance with our methamphetamine patients. That's the way we treat pulmonary hypertension in 2023, I would say. The other aspect of treatment is that the heterogeneity of the population that we deal with, both in the initial phenotyping across different continents, but also the evolution of comorbidities in our patients that develop, including renal and hepatic failure, interstitial lung disease and connective tissue disease patients, and essentially a variety of consequences of end-stage pulmonary vascular disease that now arise to the notion of managing a chronic disease. And then obviously at the end of the line, as we've talked about yesterday and today and continue to do so, the failure of triple therapy today results in either the need for life-saving devices, either as a therapeutic or a bridge to transplantation. And that's where we are really the state of practice. So 2 decades of extreme amount of work have brought us to this point where we have multiple classes of therapies with multiple routes of administration. And now a soon to be a new class that has generated a lot of excitement that you all in this room and colleagues have contributed to. The data around all these therapies have also evolved. When you look at the Super 1 trial with sildenafil and PAH and the early BREATHE studies, we were doing 12 weeks, 6-minute walking distance changes in patients that were primarily very much minimally treated. As we evolved through therapeutic options, we went to longer studies, including event-driven studies of mega numbers of patients, 1,200 PAH patients, demonstrating the superiority of selexipag over placebo. And in the same breath, we can test different doses now all of a sudden with these. So the foundational approach for treatment in PAH from a clinical drug development has been a phase 2 proof of concept hemodynamic primary endpoint with exploratory secondary endpoints, including 6-minute walking distance and exploratory endpoints, and then a pivotal study, phase 3 study, 6-minute walking distance with time to clinical worsening and morbidity and mortality as a follow-up. And I'm not going to reiterate the beautiful presentation that Marius gave already, the data around sotatercept and its impact both as a phase 2 and as a phase 3 studies, both hemodynamics, clinical, and morbidity and mortality. But I'm going to argue with you that we don't have any evidence, and we haven't tested the evidence for disease modification or reverse vascular remodeling. And so we have to be careful about how we step into this concept and construct. And recently, our Canadian colleagues published a systematic review using a frequentist random effects network meta-analysis of 53 randomized clinical trials in over 10,000 PAH patients. And I'm going to orient you to the main screen here. In this column up and down are therapies by classes. I'm sorry, this is small, but I'll go through it with you. So these are therapies by classes down in this column. These columns are clinical endpoints, hemodynamic endpoints, and safety. And what these colleagues did was they evaluated the absolute risk reduction per 1,000 patients from all these studies through their network analysis and considered the minimal important difference of each of those variables in the bottom category here. And then they did an assignment in their opinion that whether the data demonstrates benefit over standard of care, no difference, or inferior to the standard of care. Negative values here reflect a lower event rate. So if you look at this in terms of time to clinical worsening, generally you will see what the notions that we have is that the therapies reduce events and clinical worsening. It's not so easy to see the same thing in terms of 6-minute walking distance, and the bigger graphic here is that in terms of the effect estimates on those from across those clinical trials. And finally, you can see relatively beneficial effects that we have on hemodynamics. This slide, for me, I don't know how to feel about it. I don't know how to feel about the study because after 2 decades of practicing and reading, I've always felt that it's surprising to me that some of these studies may be not showing superiority in terms of ability to improve 6-minute walking distance. And so I think in 2023, we sit here, we conceptualize therapies in 2 different frameworks. One, we think that the data may be equal across all the therapies that we have, and that those therapies have been evaluated in the same type of patients, and that's not true. Our initial clinical trials were of patients different perspective in their pathophysiology and clinical journey in pulmonary vascular disease. So we have to recognize that. We have to recognize where we stand today. So, and ultimately, we have our guidelines, the ESC-ERS guidelines, which through risk stratification ask us to think about upfront aggressive therapy, and think about comorbidities on the right-hand side of the graphic and how those comorbidities, in the view that might be different across Europe and the US or North America, contribute to our decision-making in terms of therapy. In this algorithm, you do monotherapy and you think about expert opinion approach, and that's really what ends up happening. I could tell you, a lot of our obese PAH patients in my clinic receive multiple therapies eventually. So the easier part is clinical practice is guided by common principles. As physicians, we interpret the data of clinical trials. We look at the patient within the scope of inclusion-exclusion criteria that are applied. And we have to think of trials that either underrepresent some of our patients or don't show the magnitude of effect that we think that those patients will have. Connective tissue disease patients, methamphetamine-induced pulmonary arterial hypertension patients don't see the magnitude of effect that our heritable and idiopathic see. And then there is a secondary layer, the regulatory label, that tells us you could prescribe this for New York Heart Class 2 and 3 patients. But we take those, and we take privilege in how we practice our clinical daily lives. And really, the one thing that we don't think about often, certainly not often enough, is the impact that real life issues have on how our patients can tolerate or even be authorized for therapies. I would suggest to you that last time I tried dual oral upfront therapy or dual IV plus oral upfront therapy, it is a big work for my front office staff to do that kind of practice. So those do impact our clinical daily lives, and we have to think about what it means for us to begin to think about the age of disease modifiers. I'll share with you surprising data as well. Again, this is from our Vero Moulton Wall Center database from 2001 to current. We have over 1,000 patients. And recently, as a part of a quality of care initiative, we looked at our morbidity and mortality. And our presumption was our survival by 5-year increments should improve because we've gotten better and better, or we think we've gotten better and better. And if you see this is difficult to see, but 2005 to 2009, it looks like our clinic, we were seeing a slight improvement in short-term prognosis in our patients, but we slid back in 2010 and then 2015 to 2019. I can't show you that we have any superior outcomes in terms of our PAH patients, probably a much more sick group of patients. We haven't adjusted this, but this is preliminary data to say that we have to step back and think. We see large registry data, and we think that we have gotten better with treating our patients. Maybe we haven't. Maybe we should be thinking deeply. And the last thing from a clinical practice perspective I'll say is that pulmonary hypertension definition is evolving, and rightfully so. PAH in 2021 was a little bit different than maybe it is today from a definition perspective. 2001 certainly was. And so the data that we have accrued across clinical trials don't really tell us how we should treat our borderline PAH patients. And with that, I think that we have to take a step back and understand that that's the reality of clinical practice today. So I think I'll switch over to what I think are the two most important words in the next decade I predict that's going to be for us to address as a community. The American Journal of Respiratory Critical Care Medicine, the Blue Journal, asked us to do a perspective on what is disease modification in PAH, and we have a working group. And the first thing that people said was, well, I know when I see it. I know when I see it. That's how I'm going to approach it. I'm going to see this profound improvement in hemodynamics, and that's disease modification. Some people think that reverse remodeling should be part of the definition. How about long-term super survivors, or improving short-term and long-term survival to the point that we've never seen before? And the other question about disease modification in pulmonary vascular disease is, as has been talked about yesterday and today, are we talking about a disease that's solely in the pulmonary vasculature, or should the disease modification construct be in the scope of the right ventricle as well? And how do we think about that? How do we measure that? So the first thing that we did as a working group, we said, well, there's a spectrum of treatment response. You can give a patient a treatment that could harm them. You can give a patient a treatment that doesn't do really anything. And then you give treatments that have maybe some good response. And then you have this futuristic view of cure, which probably are not there yet. So we think disease modification will fall within that scale. So then we said, well, then there must be main issues to address in terms of disease modification. And we came up with 3 major pillars. The first one is, how do we measure disease modification? And we understand that pathology is impossible to access, at least today, from a traditional perspective. Maybe futuristic tools like optical coherence tomography or some of the CT work will help us understand the microvascular structure. Traditional endpoints are usually used in our clinical trials, and we wondered how those traditional endpoints, what is the scale and the magnitude of those endpoints that need to be registered for us to consider a disease, a drug, a disease modifier. And I would say that by itself, this may be a big question, but that is part of one of the 3 pillars. I've already mentioned maybe the use of imaging modalities or even endothelial function testing with provocative challenges like nitric oxide. And how do we think the RV, how do we measure the impact our therapies have on the RV, and what do we think about the magnitude of that impact? So we need to, as a field, address this question, how are we going to measure it? And I will just point back out to some of my colleagues that analysis of FDA data published almost now a decade ago showed that we can't explain, at least on that day we couldn't explain, the entirety of a therapeutic effect by just hemodynamics. That PA pressures and PVR only accounted for about 14 to 20% of the magnitude of effect of our therapies that we had. So then becomes the second pillar. And the second pillar has to be that mechanism of action is relevant. And I think this is probably why you put me in this talk, because we're talking about not vasodilators per se or vasoactive substances, but the next decade of PAH therapy are about anti-remodeling agents, or metabolic modulators, and pathways that may have actually impact on the structure and the function of our pulmonary vascular bed. And finally, I would suggest, and I think we suggest, that the third pillar of this construct is the sustainability of the treatment effect. And we cannot study the sustainability of the treatment effect without thinking about the withdrawal paradigm. We are no longer in 2010, where we have to be bound by concerns around care and maybe, I'll be provocative, ethically bound by the concern that we can't watch a patient during a withdrawal mechanism. With all the tools, with all the knowledge, with the frontier of digital health and wearables, we can come with a construct of how to study withdrawal properly. And then the question becomes, do we withdraw the agent that we tested, or do we withdraw the agents that our patients are on in terms of background? My personal opinion is that you have to withdraw the testing agent to show the sustainability of effect, but this brings up another point, is how long do you withdraw it for? And nobody knows. And then I think the last thing here, before going to the next slide, is in our working group, we actually have a patient who's a physician, who is actually trained here in Tufts. Idiopathic vasoreactive patient who's syncopized while rounding on the PH service. So she gives us a perspective of a physician who is also a patient. And we can't forget this. And what she said was, and we actually got approval from the Blue Journal to include this as a write-up from a patient's personal perspective. And what she said is, you have to think about disease modifiers that have tangible impact on how I feel and I function. And tell us, what does disease modification mean? Really, does it mean? Is it a cure? Or am I risking something else? And so I think the patient's perspective has to be considered, and I think this is early days, into this construct of how we go about studying disease modification. So in conclusion, I'll say that there's heterogeneity in treatment patterns. There's heterogeneity in phenotypes and our practice patterns and our treatment responses in our patients. And I think that I've provided a construct of how we go about thinking about disease modification. But Aaron, your question to me wasn't about this, give us an answer. And I would say, in my opinion, this is how it's going to impact our treatment. We have to come up with a consensus definition of disease modification. We have to study this clearly with this goal in mind in our randomized clinical trials of disease-modifying anti-pulmonary hypertension therapies, DMAFs, whatever you want to call it. And then you get to the point where you stabilize patients from a treatment perspective. You give them a drug that you think is a disease modifier, and then you withdraw the background therapies with the hope of seeing the sustainability of effect. So I would suggest to you that in my clinical practice, if I'm convinced that something is a real disease modifier, that I think that I could demonstrate in those pillars and the patient's perspective that this is highly effective therapy, novel in our field, then I think the upfront scenarios will come into play very, very quickly after that. Today, I don't know what we'll do when sotatercept comes on the market. Probably use it within its scope of label, within the randomized clinical trial that was conducted. But I bet you there are going to be patients who are going to be pushing for it to replace their background IV therapies that they hate, or receive it upfront quadruple therapy, if that's even possible. So with that, thank you again for having me out here. I want to thank the group. These are the guys that you see within our working group. This is our patient, everyone else here, and I have to say that we also have the colleagues from the FDA represented in this working group. Thank you very much.
So while everybody's getting settled, so Roham, great talk anyway. But just to get to your final point, there are a couple of cases in the literature of people with HIV, PAH, who over time on therapy normalized and actually came off therapy and have been off therapy for years now. So that's the only, and I think there's like 4 or 5 of them, maybe 3 or 4 of them. So I suppose under the right circumstances, potentially with the right subset of PAH, and these people also obviously they're on antiretroviral therapy, it might be possible. But in general, I agree with you. I mean, I don't know. We have to define it, and I have no idea that we've actually, quote, cured anybody.
I agree with you.
So I love your idea about withdrawal, I would point you to something from the left heart world where Milt Packer and Fayez Zanad in the Emperor studies had empagliflozin and withdrew it for 30 days from 7,000 patients to look at the effect of what happens from drug withdrawal. And they built this into the original trials, both Emperor preserved and Emperor reduced. And so maybe that's something the trialists could tell us whether that's feasible to do.
Yeah. I would just say that I think within the construct of, let's just assume a proof of concept phase 2 study, PVR as a primary endpoint. The next question becomes, after 6 months, you repeat the right heart catheterization. Are you going to repeat a third right heart catheterization in a month after? Or do we begin to develop constructs of surrogates of response? Do we study vascular volumes and vascular architecture alongside with the hemodynamics? And when we withdraw the drug, we don't necessarily recatheterize them. But I think this is the level that we need to be thinking about.
So that's sort of been done way back when. There was a study in which people were on IV propranolol, and before they got switched to IV treprostinil, they actually withdrew the propranolol and saw what happened. And most of the people, as you would guess, did not do well very quickly. The longest person who lasted before hemodynamics changed was about 23 days or something like that.
But I think if I understand this correctly, I think that's really given us a black eye on how we think about withdrawal studies.
Oh, yeah.
We can't compare that. Those are the days where we just had those agents, right? You withdrew them on nothing else, right? And so I would agree with you. Back in those days, it would probably
Yeah.
Yeah, but that's really held us back from us in this field to think about withdrawal when we, in this day and age, we do think that we can stabilize our patients or rescue them very quickly. How patients feel about that, though,
Right.
that's what my patient said. She said, I'm stable. Why would I want to mess with anything else?
Oh, absolutely.
A question, Roham. Could we look at data from the trials up front? Or, for example, in the endothelin receptor trials, Lou got up and said, and was told never to say it again, but there were 30% non-responders. So could we identify a group of people from the mass data that say have two standard deviations from the mean response? I mean, some of Lou's patients walked about 10 feet further after 12 weeks of an endothelin antagonist. Could we identify those people up front, justify withdrawing a drug that doesn't appear to work for them, and going on to adding whatever the new and super is, and look at it from that perspective, personalize the data? I mean, I've done this for 30 years and never withdrawn a patient because of the fear of bumping them off in that short term, as Hap described.
Yeah. I mean, clearly within the data, within sotatercept data, I think you see that there are patients who are extreme responders. And the real question, I think, then becomes, I'll say that our regulatory colleagues are profoundly stuck with the idea of withdrawing the experimental therapy and not a background therapy to understand if that therapy itself, the investigational therapy, is a disease modifier.
Great talks again. So I get that sotatercept stuff is exciting. Activin is a clinically validated pathway, but activin is not the whole thing of TGA-beta BMP imbalance. So there's preclinical data suggesting TGA-beta might be important. So why has that not been tested in human? Is it because of the translation issue, or there's a concern on safety profile? So I guess Marius, maybe even audience, other panelists can offer some answer.
Everybody's looking at me. That's not fair. I mean, there are so many potential compounds out that are promising, why have most of them not being tried? I wouldn't be able to answer that. I mean, you know how complex it is. You have to have the preclinical data. You have to have money. It's not easy to get. So it's very complex. So maybe the miracle drug is already out. We just don't know.
So I have a theoretical question for you.
Wait, we have one more. We have an answer here.
Why we don't have tested the TGF-beta pathway modulators directly? I don't know.
There you go. There's the drugs out there.
It's
We just don't
also
know where
hard
it
because
is.
you would have to get directed therapy. Because if you tried to inhibit the entire TGF-beta pathway, you're going to have profound effects in other parts. So if you can get directed therapy, that's a different story.
I see. So if you think there's a way to harness TGF-beta, that's,
I'm sorry, I missed that with it. I don't know, somebody just yelled something out.
Not in cancer, TGF inhibitors alter blood vessels, and the effects were so broad that they felt that they could not continue in people because it targeted it with so many
Yeah.
off-target sites.
I mean, usually the way around that, though, is to direct it, right? So either encapsulate it, liposome, something. Yeah.
I can comment on this a little bit. You're absolutely right. The original small molecules for inhibiting TGF-beta were way too broad and cardiotoxic. They're being used in limited settings, intermittently dosed at low potency to get around that. But they're very broad. They inhibit half the pathway. They inhibit like 17 out of 33 ligands. We investigated TGF-BR2-FC as a selective beta-1, beta-3.
I read your paper.
Yeah, so that compound is still alive at Merck, and some of the folks in Merck know that this is being tested in scleroderma, but not specifically for PAH. Probably a tolerable strategy, but not as tolerable as sotatercept. And I don't think any of the endpoints involve pulmonary hypertension and scleroderma, but I'm wondering if that might be a part of their trial design. I don't know enough.
So actually,
Anton is a
I can't see over there.
Yeah, I'm very small, Hep. I know.
No, you got to get taller than the.
I really enjoyed the presentations of all, but especially from Sebastien, because then when I hear this, I do think I've chosen the wrong job. But still, I have difficulty to connect. Of course, we might have some difference in interpretation of the PET scanning, but these metabolic changes are there, certainly, and you can act on them, and then you get reverse remodeling, as you showed nicely. Do you think it's real the cause of the disease or probably the consequence? Does it really matter? Probably not. And how does this fit into the impact we have now, at least in trying to restore the sotatercept success? What's your opinion about this? And especially also, how should we continue in the metabolic changes field? So, a couple of questions.
I think it was for you, Sebastien.
I know, but I didn't get the question.
Anton, he didn't understand the question.
Never ask 3 questions in one.
The Dutch accent.
The first question is it the metabolic change? Do you think it's the cause or the consequence of the disease?
Well, it's actually both. Okay, so I think there is this is a response to stress and proliferation. Your cells need to adjust its metabolism to the environment. So this, by creating that, you can accelerate and sustain the development of the disease. So it's kind of both. It causes the disease, but it also consequences of the disease in that situation. So I got that question. What was the other one?
Okay, so that was the first question. Then the second question indeed is, when we are really targeting these metabolic changes, then we also act on the different systems in the body, which also has an impact on stress and response.
Yeah.
And so is this doable to do this type of trials with these drugs?
Yes, it's doable. It has been done by Michaelakis and Martin Leopold. And the metabolism now we know by doing biopsies, like skeletal muscle biopsies, for example, from PH patients, we found exactly the same metabolic disorders and signature in many different organs in PH patients. So I am one of these researchers that believe that pulmonary hypertension is more systemic disease than the restricted to the lungs type of thing. And is it a cause or a consequence of the lung dysfunction, the metabolism disorders in every other organs? This I don't know, but I'm truly convinced, and we have evidence directly from patients, that there is modification of the metabolism everywhere in the PH patients. So I believe in that. So it's doable.
And this brings me to the third question, and that's the relationship with the sotatercept, because if the sotatercept is indeed really curing the vessels, then I would also think that the metabolic changes moves to the right way. Is that correct?
Well, I'm not sure that, personally, I'm not sure that sotatercept is a true anti-remodeling agent. I think it's a combination of boosting oxygen delivery. It's probably doing a down the road a kind of anti-remodeling effect as well. And I'm totally convinced by the efficacy of sotatercept. I mean, clinically, the data are here, and it's wonderful news. But from a research perspective, I think that you will not be able to reverse totally pulmonary hypertension with sotatercept, because I think the reprogrammation of the metabolism, which lead to the reprogrammation of gene expression, is always here. As long as you don't block what caused the activity of activin, here right now we're just blocking activin, but we are not blocking what in the disease process is making the activation of that pathway. And this is a gene reprogramming, and I think metabolism is key in gene reprogramming through the production of acetyl-CoA, basically. So I think as long as you keep sotatercept in the patient, you will have probably the positive effect. But like if we talk like Roham was suggesting, sure, as soon as you're going to remove it, it's going to come back and fly again.
Thank you.
Hillary?
I have one comment and one question. My comment is just with withdrawal of therapy, I think we will need to kind of standardize an approach of how we do it. And one patient population where we withdraw therapy a lot is the portal pulmonary hypertension patients post-liver transplant. So maybe taking some of that experience of how we taper them post-transplant and then extrapolating it to other patients as well will be kind of an interesting paradigm. But my question was related to compliance. So we presented a lot of data on improvements in compliance, and is there any known information about a minimal clinically important difference? Like, is it percent change that matters, or achieving an absolute threshold, or does any change seem to be important?
Yeah, I think the only thing we know from the data is achieving a compliance of 3, and that 3 and above is associated with better outcomes. We don't know anything about minimally important difference.
Mm-hmm. Thanks.
So, I've got a theoretical question for you and Paul, probably. So obviously the data with sotatercept are amazing, okay? But if you look at the side effects are mostly vascular in one way or another. So obviously we're manipulating a pretty potent system here. So the question will be is, 2, 3, 5, 10 years down the line, if people keep taking this, are we going to end up with vascular effects that we obviously don't know now, but are going to be potentially, I'm not going to say catastrophic, but drug limiting and stuff like that?
Yeah, I can start, but I'd like to hear Paul's ideas about this, especially with a look in the future and the new developments that are coming. I mean, this is the chief concern. This is the chief concern. And I'm getting back to the withdrawal study discussion here, because I think that's related. Unlike Roham, I'm not so sure that we need the disease modification discussion. I think it's distracting from more important things. However, I'm fully convinced that we need the withdrawal studies simply for safety, because patients will stop, for whatever reasons, these treatments. And we need to know what's happening. And the safest thing to find out what's happening is to have a setting like we had in clinical trials, where the patients would come to the center every 3 weeks. So having them on drug and having them improvement, coming back every 3 weeks, then we can randomize to stop the treatment, continue, and see what's happening. And we have the clinical impression, we have NT-proBNP, we have echo. I think we don't even have to have the hemodynamics at every stage. So I think this is important. But we discussed this with almost all our patients, and we have about 40 patients in the sotatercept program right now. And they all are interested to know whether they now have to take this drug forever, especially with the concerns about the aggravation of side effects over time, which we don't see yet, but it's very early. And they want to know. So again, I think this is not something we need to know. But the thing is, we know the side effect profile for up to 3 to 4, 5 years, but mostly 3 to 4 years now. So it doesn't seem to get worse. And we don't see now patients starting to come off the drug, or patients have like systemic manifestations that are concerning. But it's not 10 years. We know, for instance, how long it takes in HHT until the patients really develop symptoms. It's much more than 10 years. So we can't be certain about this. But I'd like to hear from Paul what you believe in terms of the new developments, the drugs that I pointed out, in terms of their potential efficacy maybe, but especially safety.
Yeah. Right. Well, okay. This is an area that I think a lot of people have interest in, and there's no easy answer, but the vascular malformations, we don't know if that's an inevitable consequence of opposing activin, because none of the agents that we have right now are entirely monoselective for ligands. But on the other hand, when we've used preclinical models where we've just isolated 1 or 2 ligands, the efficacy isn't there. It seems like all these ligands work together in a semi-redundant fashion, and if you don't block a cluster of them, you don't get the efficacy. So the new traps from Kuros and from the other companies inevitably that will come are designed to test the hypothesis that maybe there's some aspect of selectivity that's responsible for the vascular malformations, the bleeding, maybe even the platelet effects. Certainly you can dial out the erythrocyte promoting effects. That seems to be clear from the non-human primate and human data. But as far as bleeding, you won't know until you try it.
Well, the reason I bring it up is there is a clinical syndrome of activin abnormalities, if you will, that does cause GI bleeding and GI, sort of like HHT in your gut. And so I'm wondering if long-term manipulation of this is going to end up with a lot of patients with what looks like HHT in their gut. I don't know. But I mean, it's just something to, think about. It's not obviously not going to affect the uptake of the drug, but down the road it may.
The same genes that cause heritable pulmonary hypertension also cause HHT. So yep. I think we have to learn a little bit more about how the perturbations in the signaling pathway might be biasing us towards that spectrum of phenotypes. And some of our patients have both syndromes, right? And so have we shifted the balance in that way invariably for opposing the remodeling in this way? But I think the experiment needs to be done. And we're just, I think, starting to introduce those tools in the clinic to test that question. I think that the metabolism is an incredible lever into this system and the epigenetics. I think that when we're exposing our vascular cells to powerful fate-modifying signals like TGF-beta and activin, we are affecting the epigenetics. And I totally agree that going upstream is probably going to get to the cause if we can identify what those upstream causes are. But I have a feeling that we are subtly, or maybe not so subtly, changing the fate of our cells by intercepting these signals that are responsible for maintaining the identity of the vascular cells and sometimes promoting fibrosis. And activin is definitely a fibrotic mediator.
I have a question for you, Paul, because we're talking about redrawing drugs. Have you done it in animal model? Like, have you treated your animal model with sotatercept for months and then redraw everything and see if pulmonary hypertension was reoccurring somehow? Because this is easy things to do in animal model. We never done it. I know a lot of questions about how good are the animal models, but we could definitely do it tomorrow morning in our labs. Treat animal with standard of care plus sotatercept for months, have a stabilized PA pressures, and then remove one drug at a time and see how.
I think it's totally feasible. It's just probably expensive to do, but these models have the animals in these severe models clearly have a life expectancy that's predictable after the onset. And so whether or not you've changed that after a pulse of these treatments and then withdrawing, that would be a new bar for preclinical work, but I think that would be really interesting.
Quick question, because
Quick question for Marius. Merck, to their credit, was taking blood at the beginning and going to look at it at the end to see if they could predict who would responders be. I'm not asking for the results, but is that going to be coming at some point in time so that we could kind of weight our introductions based on biomarkers or something?
It's not going to happen in the near future. I mean, we tried this with all the drug. I remember we tried this severely with imatinib. Doesn't work. And to the best of my knowledge, from what we can tell from the data that I've seen for sotatercept, there's no predictor. It's always the same. The patients that I predict the most from any kind of treatment are the young females with no comorbidities. It's true for any treatment. It's probably true for the tyrosine kinase inhibitors and the activin signaling inhibitors, but biomarkers are yet a failure.
Okay, why don't we break for lunch?